Hello, everyone. Welcome, and thank you for joining us today for our second virtual event. This is something we're looking to do on a quarterly basis, so if you're interested in being a future presenter, please let us know. We will be sending a short survey out after the event. Please take a moment to fill it out, as your feedback is very valuable to us and helps guide us improve for future events. Today we're joined by Brigette Rabel, who is the Synoptic Reporting Provincial Coordinator for British Columbia. Her presentation will delve into how discrete data from Pathology Synoptic checklists maintained by mTuitive feeds into BC's own central data repository. With this data, BC has developed individual dashboards for pathologists and surgeons to display a set of quality metrics specific to their practices and allows them to compare results amongst their facility, health authority, and within the province as a whole. This presentation will also be followed by a Q&A session with a panel of experts. Just a side note, our settings automatically mute all attendees. So when you have questions, you can ask them by clicking on the Q&A box at the bottom of the screen. If you have questions that our panelists cannot get to or think of something after, just email julie@mtuitive.com and we will get answers for you. So without further ado, I welcome Brigette.
Thanks, Julie. Can you see my screen all right?
Oh, yes, we can.
Okay. So hi everyone, my name is Brigette Rabel. I am the Pathology Synoptic Reporting Coordinator for BC. A bit about my background. So I was trained as a lab technologist. I spent time working in the anatomical pathology lab and with the lab information services team. It was in that previous role with LIS that I became involved with the implementation of Expert for Pathology. In 2016, the provincial coordinator position was created, and I've been in this role ever since. Here's my disclosure statement. So I'm an employee of the Provincial Health Services Authority, and I'm not being compensated for giving this presentation, nor do I have secondary interests. Here's an overview of the things I'll be speaking about today. First, BC's implementation of expert synoptic reporting and the central data repository, what we call the CDR. I'll show you the first generation pathologist feedback reports I created. Then I'll talk about the synoptic reporting knowledge mobilization project. This month, this project is wrapping up at the end of this month, and it's within this project that we created the pathologist and the surgeon dashboards, as well as the communities of practice. Then I'll talk a bit about what the CDR data revealed, what we learned by looking at the data, and I will list some of the research and quality improvement initiatives that we've been involved with. So here's a map of BC. We are on Canada's west coast. We are Canada's third most populous province after Ontario and Quebec. The population of BC is just over 5 million people, and approximately half of BC's residents live in the Greater Vancouver, Lower Mainland area. We have 5 health authorities plus BC Cancer, 23 pathology sites, and around 200 pathologists. When BC decided to implement synoptic reporting software, we were looking for one tool that would interface with the 4 lab information systems used in BC. So those systems were Meditech Client Server, Cerner PathNet, Cerner CoPath, and Sunquest CoPath. mTuitive's Expert was able to interface with each of these systems. So in 2012, BC signed a contract with mTuitive. And over the next 5 years, we rolled out Expert across all pathology sites in BC. In 2016, BC implemented mTuitive's Central Data Repository. The CDR allows us to start collecting discrete tumor data in a single database from all submitted checklists reported in BC. So the CDR was built by mTuitive and it lives on a server within BC. Here's a high-level view of the data flow. The computer at the top is where the pathologist works. When they have a tumor to report, they launch the Expert software from within the LIS. After completing the synoptic report, they click Submit in Expert, and the data goes back to the LIS to be embedded in the pathology report. At the same time, the checklist data is sent to the CDR. When the case is signed out in the LIS, a message is generated to send patient data to the CDR. So in the CDR, the tumor data from expert is linked with the patient data from the LIS. The CDR then can be mined for a variety of different reports, as I will show you. Also, mTuitive created a feed that sends CDR data directly to BC's tumor registry. This feed is set up to run automatically on a bi-weekly schedule. This graph shows that since the implementation of the CDR, the number of synoptic reports is growing steadily. We currently have data on over 65,000 individual synoptic reports associated with over 55,000 patients. So we were collecting vast amounts of discrete data very quickly, but at the beginning, we didn't know how best to put it to use. We started with the Bisrey indicators developed by the Canadian Partnership Against Cancer, or CPAC. CPAC provided a list of clinical indicators for the top 5 tumor sites, plus 3 data quality indicators. So I went about analyzing the CDR data to create those CPAC indicators. My process in the beginning was to use Tableau software to do my data extract, then using Excel to manipulate the data and create the reports. The raw data in the CDR was not structured in a way that allowed me to report it out directly, and a significant amount of manipulation was required on my part. The process was quite slow and very tedious. I knew there was a way to create these reports more efficiently, so I attended Tableau training sessions and I spent hours on Google and YouTube, but it seemed I was doing all I could within Tableau and Excel, so I carried on. Here's an example to show how those early reports were formatted. So this shows data at the health authority level, at the institutional level, and at the pathologist level. So as you can imagine, these reports grew very lengthy. Each tumor site had its own report, and each indicator was reported on a separate page. There's a ton of information included in these reports, but they just weren't all that useful. Pathologists could see the results compared to their peers, but it wasn't clear what it all meant or what they should do with it. The feedback we received from the pathologists was that the Excel reports they received were quite cumbersome and difficult to navigate. Around that same time, we started hearing buzzwords like dashboard and scorecard and KPIs. We wanted to create that one-page dashboard containing a short list of the most relevant and actionable metrics for the pathologist or for the surgeon. Something they could look at to get a quick snapshot of their practice compared to that of their peers. We also wanted to show how the results were trending over time. So we knew what we wanted to create, but we lacked the resources and the expertise within our team to do this. Then in 2017, BC partnered with the Canadian Partnership Against Cancer and launched the Synoptic Reporting Knowledge Mobilization Project. The first goal of this project was to build comparative feedback reports for pathologists and surgeons. We started calling this the dashboard. The second goal of the project was to create communities of practice. Within these groups, clinicians could discuss the data they received and try to better understand why variation exists and what the impact is on patient care. I'll talk a little bit more later about communities of practice. First, I want to tell you how we created the dashboard. The first thing we set out to do was to add a new member to our team to help us. We had an idea of what we wanted to create, but we didn't know what particular skill set we needed our candidate to have or what tools they should be proficient in. To be honest, we didn't get it right at the beginning, and our first couple hires turned out not to be a good fit, but we kept on searching. Along the way, we were put in contact with Gurpal Bisra and his team at Bisrey Analytics. Gurpal's team had a background in public healthcare, and this was definitely an asset. They understood the constraints of our unique working environment. They prioritized already approved software. They understood privacy restrictions, and they had experience creating reports for various quality improvement initiatives. So we hired Bisrey Analytics on a contract basis. While they continued working their regular 9-to-5 jobs. They worked on our project in the evenings, and we worked together on site on the weekends. With their strong work ethic and commitment to the project, we continued this alternative work schedule for 2 years. And I only mention this here to highlight how important it was for us all to be open to having a flexible work schedule. We believed Bisrey Analytics was the right fit for us, so we all adapted to make it work. So for those who are interested, I want to talk a bit about the technical details related to creating the dashboard. So in the CDR database, data is stored at the question answer level. So each row of data is a separate question answer combination. This means that in the database, there are multiple rows all belonging to one checklist. And all these rows needed to be linked before we could do any reporting. All this linking, that was the manual work I was doing in Excel. So Gurpal's team understood we needed to aggregate these records at various levels. And to do this efficiently, the aggregation had to be automated. So I'll explain each of these colored boxes if you can't read them right now. They'll come up on a future slide. So to do the data aggregation, there are a variety of tools available. Two of the more popular tools are SQL and R. Gurpal's team did a thorough evaluation of SQL and R to decide which would work best in our situation. At the end of their evaluation, they chose SQL. SQL is widely used within our organization, so we know the software is maintained and upgraded regularly. SQL stored procedures can be set up to run automatically in the background. SQL runs on a server, so we don't need a dedicated PC always turned on to host the program, like with R. SQL has the ability to join existing data to aliasing tables to automate the de-identification of data. And SQL can compute aggregate level values much faster than R. Gurpal's team did use R for some internal reports. Gurpal's team created a great report using R that performs statistical testing to identify true outliers. But for setting up the tables for the dashboards, they use SQL. So for data analysis and manipulation, we use SQL. Then for data reporting, we chose Excel. Some of the benefits of using Excel are that it integrates well with SQL Server because they're both Microsoft Office tools. Excel has powerful pivot table and graphing capabilities already built into the program. Excel is standard software installed on all PCs across the province in our health authorities, so no additional ongoing software licenses are required. And end users are familiar with Excel, so minimal training is needed. We chose SharePoint to host the reports and Outlook to distribute the dashboard. So the benefits of SharePoint are that pathologists can access the dashboard whenever it's convenient for them. Like SQL and Excel, SharePoint is standard software across all health authorities. Access to SharePoint is easily maintained by me, and it is tied to user login, so no additional usernames and passwords are required. And access to SharePoint is internal only. It can't be accessed from outside the healthcare network. So the pathologists access their dashboards on the SharePoint site. Surgeons, on the other hand, they opted to receive the reports emailed to them as a PDF. Since Outlook interfaces easily with Excel, report distribution by email is simple. With a click of a button, a VBA macro kicks off in the background, and the PDF is automatically emailed directly to surgeons. So I want to point out here that we were able to create and deliver the final reports using software already available within our organization. There are many reporting tools available, but most of these require ongoing maintenance fees and annual licensing fees. It was important to us that the dashboard be sustainable. We knew that once the project was over, there'd be no funding to cover costs in keeping the dashboard available. So this slide is just to remind you of the manual process I showed you earlier. This process shows how I use Tableau to extract the raw data and I did my manual manipulations in Excel to create my reports. Gurpal's team expanded on this by creating additional tables, views, and stored procedures in SQL. Now all that data manipulation happens automatically in the background. And this is what the data mapping looks like now. So the red boxes, those are the original tables created by mTuitive. They make up the CDR. The other boxes were created by Gurpal's team. So the orange boxes are SQL tables or views. The blue boxes are SQL stored procedures, and the green boxes are Excel. So that is the technical component to creating reports, but we also had the task of deciding which indicators to include. So we reached out to different experts for guidance on this. We worked with our Synoptic Reporting Advisory Committee, our checklist champions, our surgery leads, and pathologist special interest groups. We also searched the literature for any metrics used by other organizations. So we looked to those expert groups to help us identify specific criteria to make the metrics most meaningful. Here are some of the recommendations, and we can expect more recommendations as we continue to look at the data and as protocols change. So that's how we decided which metrics to include. We started with the CPAC ESPRI indicators, then we worked with various groups to create the indicators specific to the pathologist and the surgeon's practice. And this is what we came up with. So this is the pathologist dashboard. Pathologists access this dashboard from SharePoint. They can access it anytime, whenever it's convenient for them. It's an Excel report that is refreshed every week. Pathologists are given their unique ID. So the first thing they do is when they open the dashboard is they select their ID from the list. When they choose, then they choose the year they want to see data for. The rows highlighted in gray show the number of checklists submitted for each tumor type. This checklist shows metrics for breast, colorectal, endometrium, and prostate. We also have metrics set up for lung cancer. They're just not showed in this example. We also report turnaround times. We have a turnaround times for all tumor types combined and separately by tumor type. So the column labeled with the pathologist's unique ID shows the pathologist level results. Pathologists can then compare their results against results from in the other columns, the site, the health authority, and the provincial average. For any metric that has a suggested or published target, that is also listed. And when there is a target, a green circle indicates that results are within range, and the yellow triangle shows that results are outside the range. This is the surgeon dashboard, so it looks similar to the pathologist dashboard, but the delivery model is different. So where the pathologist can access the report on the SharePoint site, the surgeons instead chose to receive their dashboard as a PDF report emailed them once per year. Each indicator listed on the dashboard has what we call a deep dive page. So this graph shows a blue line, that's the pathologist results over time. The yellow and orange lines represent site, health authority, and provincial results. And there's a blue shaded area. This is the confidence interval. This helps us interpret the results, especially at those sites where the result counts or the case counts are quite low. The deep dive page also has 3 sections to give more insight into the indicator. So what we're measuring, this is a description of which cases are included and which ones are filtered out. Why it matters, some information supporting why this was selected as a quality indicator. And what you can do. So if there are best practices published, we include those here. So I walked through the creation of the Synoptic Reporting Dashboard, but this was only one goal of our 5-year project. The other goal was to develop communities of practice. Having data available to pathologists and surgeons is important, but for the data to have real impact, the organization needs a culture that supports people taking the time to review the data, to explore reasons why a variation exists, and what impact this all has on patient care. So over the course of the project, our sponsor, Dr. Nick van der Westhuizen, he took every opportunity to present findings from our synoptic reporting data. He did this at site visits with pathologists across the province, at morning rounds with surgeons, at tumor group meetings, and at surgical oncologist meetings. So these communities of practice were already established. So instead of creating separate meetings and hoping people could find the time to attend, Dr. van der Westhuizen asked to be added to the agenda for these previously scheduled meetings. Other communities of practice were newly formed groups such as special interest groups. The special interest groups were created by Dr. Cheng Hen Lee, who's the medical director at BC Cancer. These are groups made of pathologists from across BC, from major centers, and from the smaller community sites who all have an interest in a particular tumor type. These meetings have been a great forum for helping us review the synoptic data and helping us interpret the results. So we have the data and we have groups who are interested in looking at it. Next, I want to share with you some of the findings. Starting off with some things we learned regarding patterns of practice in BC. So this graph shows the tumor grade distribution of endometrial cancers in hysterectomy specimens. This demonstrates that high-grade endometrial cancers are being referred to our two major centers. And this is exactly what we would hope to see, as this is the recommended referral pattern in BC. This graph shows the percent of breast excision cases where pre-surgical therapy was given. So in 2020, the 2020 results are shown in pink. We're seeing that over time, more patients are receiving treatment prior to excision for breast cancer, but we see some variability still exists between the regions. This graph shows rates of biomarker testing for breast, colorectal, and endometrial cancers in BC. So we can see that rates of biomarker testing for breast is high across all sites. Anywhere from 85 to 100% of breast cancers are receiving biomarker testing. Where we see marked variability is in the reflex biomarker testing for colorectal and endometrial cancers. So synoptic reporting helps build a case for increased funding so all British Columbians have equal access to biomarker testing. This is an example where synoptic reporting data can be used to support system-level changes for better care. So looking at the CDR data shows many areas where pathology reporting is very consistent in BC, but we also noticed opportunities for improvement. There's a field in the breast invasive carcinoma checklist called treatment effect in the breast. This describes the tumor's response to therapy and is a strong prognostic factor for the patient's survival. This question is optional in the CAP protocol, and it was optional in our synoptic checklist. So it was often left unanswered by pathologists. But the feedback we received from our surgeons was that they wanted this reported on all cases where pre-surgical therapy was given. So we edited our checklist. Now for cases where pre-surgical therapy was given, this field is mandatory. And since making that change, we can see that in 2020, this field was reported on nearly 100% of cases. This graph shows the percent of rectal excisions where macroscopic intactness of the mesorectum was reported. So we're counting here the cases where it was reported as either complete, incomplete, or near complete. This is an important field as it describes the quality of the rectal surgery, and it should be reported whenever possible. Having a complete or total mesorectal excision reduces the rate of local recurrence and improves patient survival. So when we started monitoring this data in 2018 and 2019, we saw intactness was not being reported on all rectal cancers. Instead, some were reporting it as not applicable or cannot be determined. We can see on the graph that in region C in 2019, for instance, intactness was reported on only 85% of rectal cases. So we wanted to increase reporting rates for this field. So we made an edit to the colon and rectum checklist. We made this field mandatory when the procedure was abdominal perineal resection or low anterior resection. Then we saw an increase in the proportion of cases where this field was reported, and in 2020, it was reported in 95 to 100% of cases across our regions. This graph shows the rates of reporting whether breast biomarkers were performed on either the resection or the biopsy. Back in 2018 and 2019, we noticed variability in how pathologists were reporting that biomarkers had been performed on a previous biopsy. So we took a deeper look at the data and discovered that some pathologists answered the biomarker testing question with not performed, but then in the free text comment, they stated performed on biopsy. So this was not how we wanted the checklist to be used. This was a signal to us that the biomarker testing question and answers in the checklist were somewhat unclear. So we updated the checklist to allow pathologists to indicate clearly that biomarkers had been done. So for 2020, the data better reflects the actual rates of biomarker testing in BC. The chart shows that biomarkers are being done on 97 to 100% of breast tumors. This last graph shows the percent of cases with 12 or more lymph nodes harvested in colon resections. We excluded cases where presurgical therapy was given. So the data shows that lymph node harvest rate is variable between regions. We chose to work on this one to see if we could understand why some sites were getting a lower lymph node yield. So some steps we took, we presented data at face-to-face site visits and more recently at virtual site visits. We hosted an educational webinar on lymph node harvest. This was presented by one of our own pathologists who's a colorectal cancer specialist. And for the specific sites where the data signaled there may be a problem, we reviewed individual pathology reports looking for a reason to explain why lymph node retrieval was low. So we were looking for things like whether a fat clearing agent was used or whether a short segment of bowel was submitted. We haven't yet identified a specific reason for low yield, so this is still a work in progress. Our next step is to have our top performing site, what CPAC calls our shining star, to have them present their procedure to the other sites to see what we can all learn from their process. And as we started presenting synoptic data to various groups, word got out that about the type of data we have available, and we started receiving data requests from different groups. Here are some of the projects that we've been asked to provide synoptic data for. And I want to talk specifically about the last one, about the COVID-19 study. So in September 2020, we were contacted by researchers at UBC who were interested in learning how delayed surgical procedures and paused screening programs would impact the stage of tumors we would see over the next 3 years. They requested 3 years of baseline data for 25 tumor types, then an updated data set each quarter over the next 3 years. So this works out to 300 indicators every quarter, and this is a ton of data. It would have been unmanageable if the data had to be compiled manually. But because I could leverage the data tables set up by Gurpal's team, I managed to set up those 300 indicators. And once those were created, I was able to provide 3 years worth of baseline data quite easily. Over the next 3 years, generating updated quarterly data will be just a matter of adjusting the dates and sending the updated reports. Had we not had that infrastructure in place, those tables built for the dashboards, we would not have been able to participate in such a timely study. So it's thanks to funding from CPAC and the good work done by Gurpal's team that we're now in a really good position to share data with teams such as these who are working to improve cancer care in BC. So my goal today was to walk you through BC's experience of reporting data from mTuitive CDR. I gave you a brief description on the implementation of Expert and the CDR. I showed you how those crude first generation reports I was creating manually at the beginning. Then with funding from the Canadian Partnership Against Cancer under the Synoptic Reporting Knowledge Mobilization Project, we were able to secure the proper resources we needed to help create that one-page dashboard. I described the second goal of that project, developing the communities of practice. We worked with existing groups like morning rounds and tumor group meetings, and we created new groups, the pathologist special interest groups. In doing so, we formed new relationships with peers both in pathology and on the surgery side who are interested in reviewing the data and exploring ways it can be used to improve practices. As for what we're learning from the data, we now have the back-end infrastructure created by Bisrey Analytics that allows us to report much more than just the dashboards. I showed you how we now use CDR data to monitor patterns of practice and to identify opportunities for improvement. And as people from various programs learn about the kind of data we have, we're in a good position to share data for different research projects and quality improvement initiatives. Now our 5-year project is coming to a close. We have new infrastructure in place in terms of our data and in terms of the relationships we built with other teams. BC will continue to use synoptic data to improve patient care by providing feedback reports to clinicians, by monitoring patterns of practice, and by looking into areas where we see variability, and by exploring new opportunities where pathology data can be useful. I believe there are many opportunities out there yet to be discovered. So thank you to the Canadian Partnership Against Cancer for providing the much needed funding, for putting us in touch with expert coaches, for providing training in change management, and for creating a forum where we can make connections with our peers in other provinces across Canada. Those have all been such important pieces in helping us do this work. Thank you to Gurpal Bisra and Hans Isaki at Bisrey Analytics. You were exactly who we needed when we didn't know what we needed. And to our project managers, Catherine Young and Georgia Neindorf, who are experts at keeping us on track. And to our fearless leader, Dr. Nick van der Westhuizen, who has worked tirelessly over the past 5 years, promoting synoptic reporting and presenting data at every possible opportunity. He's passionate about synoptic reporting as an important tool for delivering pathology service of the highest standard. I am so fortunate to have had the opportunity to work with him. And lastly, I want to thank mTuitive in the day-to-day customer support of Expert product, but also in working with us when we want to create something new. Partnering with mTuitive has been a great experience. We appreciate all their support. So that's it. Thank you for your time today.
All righty. Thank you so much, Brigette. At this time, I'd like to open the floor to questions. So please send them in the Q&A box at the bottom of your screen. Please welcome our experts. She already mentioned Dr. Nick van der Westhuizen, who is the chair of the British Columbia Electronic Synoptic Pathology Program. Gurpal Bisra, who is the developer of the dashboards and co-founder and data scientist at Bisrey Analytics. And we also welcome Eric Daley, who is the clinical product manager for the Cancer Protocol and Data Standards team at the College of American Pathologists. So thank you so much. And I think we already have some questions coming through.
Here's the first one coming in. Besides pathology, what other departments would be helpful from which to derive structured data? How do you propose conducting such expansion?
Good afternoon, everybody. It's Nick van der Westhuizen here. I think the two fields where use of this sort of data would be advantageous is in surgery, and we are starting to see surgeons using synoptic checklist reporting. And the other one is medical imaging or radiology, where again, it's very similar to pathology in that it's an image-based specialty, and the reporting styles are very similar. So I think there's opportunities in medical imaging as well.
And I would just dovetail that. I would agree on that too, is that those are definitely areas that I can see those two growing. The CAP has been working hand in hand with radiology as well with some of our checklists, and trying to partner with them in some of the technology we're using to interoperatively use these forms between both sectors.
Excellent. Thank you. Another question coming in, probably best for everyone, is, are pathologists in British Columbia fully compliant in using synoptic reporting?
Hello, it's Nick van der Westhuizen. Currently, we have 83% adoption, so it's an optional program. Every pathologist in the province has the availability of using the expert system, and we have not made it mandatory currently. So we've just been trying to promote it and asking pathologists to use it. And one of the advantages of pathologists using the system is they will get these comparative feedback reports where they can compare their data with the data from the pathologists at the same site in the same health authority, and then they can compare their data with provincial data. And we also have national data that they can compare it with. So that would be one of the advantages for the pathologists who use the system.
Maybe I'll add to that the creation of the surgeon dashboards, when a surgeon wants to see his data and he knows there's cases missing, then it gives the opportunity for the surgeon to approach the pathologist at their site and encourage them to use the software.
On a personal note, I've found the run charts very valuable. So you can see your performance over time looking at run charts. For example, reporting of lymphovascular invasion rate in colorectal cancer or endometrial carcinoma. You can see how you're performing over time compared to your site and across the province, and that's very useful to me personally. The other thing I wanted to say is that in terms of the pathologist dashboard, what Brigette presented today is just the core metrics. So we got feedback from the pathologists that they just wanted, when they opened the comparative feedback reports or their dashboard, they just wanted a one-page overview of their performance. So we have just those core metrics, but you do have the ability to expand and get every additional metric that you've captured. So it's a very powerful tool. And again, I find the run charts very useful.
Yeah, when we were collaborating with Brigette, we tried to make sure that we developed infrastructure that could be scalable. So, I mean, the project is ending soon, but if she wanted to add in more checklists or more indicators, they would be automatically flowing into those final feedback reports.
Outstanding, thanks. Another question. In colon resection without 12 lymph nodes, does the system remove those ones which the colectomy is done as, for example, only to eliminate an obstruction in a very elderly patient? So is there any exemptions when they don't have the correct 12 lymph nodes in the colon resection?
So I'm assuming this is a case where there was an obstruction and then a tumor was found. If there was a cancer found and a checklist submitted, then it would be included in our data. If it was just a surgery for an obstruction, it wouldn't cross to our system if no checklist was done. We did look at those sites where we had low lymph node yield. We did look to see if, we looked through the pathology reports to see if there's any indication that it was an incidental finding, that the resection wasn't done for cancer. We didn't find that to be a case, so that wasn't a reason in our data for low lymph node yield.
Outstanding. This next question is mostly for mTuitive, really. Hello, I'm impressed by the data mining and capabilities. Does export of the synoptic data from mTuitive require any special programming by vendor, or does the client have access to the data to do it themselves? So I'll answer this, although obviously if the others have insight, please chime in. We currently at mTuitive, we're about to launch product Cedar. It's the central data repository. It's for participation from all of our clients. Hopefully we'll piggyback on the work that's being done to take advantage of this, and we hope everyone can join in with us. If you use Cedar, you'll also have access to the data. We will follow up with you about any specifics working with this particular your particular vendors or other systems that you need to collaborate with. Is there anything else any of our panel wants to respond to about that?
Yes, I would just like to emphasize how valuable having the central data repository has been for us, because we had 5 different laboratory information systems, and we wanted one system where we could just make the changes to the checklist as quickly as possible and deploy them as quickly as possible, and then have one area where all the data was stored and that we had control of that data, and then we could use that data. So it's been a very powerful tool for us having the central data repository.
Outstanding, thanks. The next question, there's 2 questions that are fairly similar, which is how many members are there in the team that deal with the implementation of synoptic data, and how many people are assigned to this project at the moment?
So I can talk about implementation of expert. So we had at the time a project manager, and then she worked with LIS teams in each of the health authorities. She also worked with IMIT. She had checklist champions, so pathologists who were reviewing the checklists and making any changes required just to reflect our patterns of practice here in BC. So it's hard to say what constitutes a team, because there were members of all these different health authorities across BC that she had to work with during that time. And then as she transferred out of that role as project manager, and then I eventually took over as program coordinator. I don't know if that answers your question.
I'd just like to expand on that. In that currently we just have 2 full-time employees that are dedicated to the project. That's the project manager and Brigette as the Provincial Synoptic Reporting Coordinator. And I think those 2 positions are crucial in terms of ongoing project analysis and support, and having one point person to troubleshoot and as a go-to person. And they've been invaluable to the success of the project. Then we've had both a steering committee to the high-level committee looking at quality improvement initiatives, and then we have an advisory committee that has both pathologists and technologists from all the health authorities that sit voluntarily on the committee. It meets bi-weekly, and we look at the checklists, how improvements can be made to the checklist, issues with the checklists, and we look at the quality improvement projects, we look at the quality improvement results, and we have quarterly quality improvement meetings. So that's basically how it's structured.
Thank you. Another question, I think you can all respond to this one, is can you monitor positivity rates of IHC biomarkers? Maybe speak of the process there.
Yes, we can. So we've actually just started looking at that just recently. So we're looking at the breast positivity rates. There's a lot of data in there. It's going to take some work looking at it to identify, to look at rates, because we have some duplicate test results. We have, either repeated at one site or repeated at another site, identifying different tumors within one case. So we are going through that, and hopefully we can get it to a place where we can actually monitor rates in a way they did that in their previous systems.
And also opinion here too, the CAP has actually been working on with the Cancer Committee. We've been developing a general IHC biomarker template as well that might also include some more of these generic IHCs that weren't included in some of our panels previously to this.
Excellent, thank you, Ian. Another question coming in is, what kind of resistance did you experience from pathologists or surgeons and eventually radiologists to implement this great resource?
That's an excellent question, and thank you for the question. So the initial resistance was that it would take more time to produce synoptic reports, because most pathologists were either giving a short narrative or just putting in the diagnosis and using variations on the CAP protocols. But I think as people started using them, they found that it was as quick, if not quicker, to use than the standard way of reporting. And you also had the advantage of using the most updated checklists that are currently available. So there was no memorization required. And also in terms of queries from clinicians about data that wasn't present in the report, pathologists soon realized that if they used electronic synoptic reporting, the number of queries that they would get would be minimal. In fact, the number of telephone calls we get to the department for queries regarding crucial data is virtually non-existent if you use the synoptic reporting checklist.
And the CAP does we do a survey every year to our licensed DCC users, and that's something very similar to what we find too, Dr. Nick, is that a lot of people, once they get antiquated to using them, they find them more efficient, and they also find them more standardized amongst the practice. So it's definitely seen amongst other users too, and there's
and the clinicians and the patients like seeing on the report the version of the checklist that was used when it was updated, and they can reference that on the internet to ensure that, and know that they're getting the best and latest checklist available. So that's been also very helpful to us.
Next question is, what are the next areas for implementation? You spoke about radiology, of course, but is there looking into quality assurance elements or any other places where you would like to see structured data being used in the healthcare or laboratory setting?
So I think the next area that we're looking at is a peer review program where you can compare the reviewers' results with the originating pathologist's results. Currently, we don't have a well-developed system for that, and it would be this setup would be an ideal area for peer review assessment, where you could present common areas where there's disagreement between a reviewer and the originating pathologist. And also it would provide the originating pathologist with feedback about the number of agreements, minor disagreements, and major disagreements in terms of tumor board reviews.
I would agree with you, Dr. Nick. I think peer review would be great. And I think treatment planning would be the other one that'd be awesome. I know they're making progress in radiology. We actually have a connect-a-thon, I think, tomorrow with some radiology folks. So I think that one's definitely starting to take off as well.
Perfect.
I think there's a great opportunity with breast imaging and pathology breast reporting for correlation with this sort of synoptic checklist pattern.
Excellent, thank you. We have time for a few more questions. Please keep sending them in. If we don't get to them, we will absolutely follow up and send out emails with the responses. Just also a reminder that this will be available as a recording for any and all who are interested. So the next question is there any data on improved outcomes as a result of synoptic reporting?
That's also a good question, and what you need is continuous accurate data. So we introduced the AJCC 8th edition synoptic reports on January the 1st, 2018, and we have very reliable, consistent data since then for the 5 major cancer sites. So we will continue to monitor that over time. But I can't honestly give you a solid answer on that question.
Rob, I would say that I think CCO has published some things, and I know it's not CCO anymore, but I do know that Cancer Care Ontario in the past had published some interesting findings too, because they as well have been monitoring on this as well. So I can look back and see if I can find some of the articles that are in the CAP archives to see if we have anything that's specific to that question, but I'm fairly positive that there is.
Is mTuitive used in other jurisdictions in Canada? How is data compared nationally? I will take the first part of that, and then you all can speak to how you work with other provinces or jurisdictions. mTuitive does currently have a large customer base across British Columbia. We're also in Ontario and Nova Scotia, and we're continuing to work to expand to other areas across more of Canada. So yes, there's a wide presence of mTuitive in Canada. And then if any of you all want to speak to how we were able to compare those pieces of structured data across these areas.
Sure, I can take this first. The CAP works hand in hand with the California Cancer Registry, and so does mTuitive as well. We also work with the CDC. CAP has quite a few grants that are funding our team to work with the cancer protocols as well as the electronic cancer checklist. I'm not sure how familiar everybody is, but the CAP as well as mTuitive have, and along with some other collaborators, have developed a technology called SDC. It's being used to interoperatively correlate results as well as pass results on from laboratories into registries into the CDC in the United States. That's one way that we're working on that.
Which reflex tests are you requiring in QKI for colon besides MMR and lung?
So I can answer for the colorectal. The only reflex testing is MMR and BRAF at the moment. For lung cancer, there's currently no reflex testing. So we are relying on the oncologists to request the testing panels that they want, and we've been in discussion with the lung tumor group to try and customize that and maybe introduce reflex testing. For endometrial carcinoma, reflex testing for MMR.
Perfect. Time for about one more question, but again, please keep sending them in. We will reach out to you with answers. And again, this will be part of the recording as well. Another question is, are you looking into implementing into genetic results as new genes are being discovered? And again, you have a couple questions about genetics reporting and cancer genetics reporting.
I mean, the CAP is definitely diving into this. We're actually maybe releasing, I believe it's either 3 or 4 more biomarker templates this next round in June. We're looking to work with some of our genetic partners to try to find a better way to release these reports so that they're more heavily adopted by the reference laboratories as well. So I think it's definitely something we're looking at and trying to acquire more customers in that basis.
There were a couple of questions about acquisition cost. Just real quick, just want to point out that mTuitive has a subscription model that lowers the cost for end users. We will reach out to everyone that asked and speak with you, obviously, in terms of working with your LIS and other systems out there.
All right, well, that concludes our webinar today. Thank you so much, Brigette Rabel, Dr. Nick van der Westhuizen, Gurpal Bisra, and Eric Daley. Thank you so much. We appreciate all of your time today. Also, thank you to everyone who joined us for this event. Please remember to fill out the survey we'll be sending out, and feel free to contact me with further questions and we'll get them answered. Email julie@mtuitive.com. And we hope to see you all again at our next event. Please take care and stay safe. Thank you.